Hello, and welcome to Missouri Pharmacy Association's Closing Gaps and Giving Shots. What we're going to talk about today is how to address vaccination hesitancy and increase vaccination rates in your practice. I'm Dr. Richard Logan, and more about me in just a few minutes. I don't know about you, but I always hate it when a speaker begins a presentation with a cheesy cartoon. But here we are. I'm going to try to work over it through the rest of the presentation, so maybe the whole presentation isn't cheesy. But I did like this one. The the man who manned the excuses for not getting vaccinated booth puts up a sign, closed until I get better. Uh, that's pretty much the theme of what we're going to be talking about today. Disclosures and conflict of interest. Many times in my speaking career have I gone over one of these disclosures and conflict slides, and it saddens me to say that I really have no conflict of interest. There's nobody out there paying me a ton of money on the backside to promote them in this particular CE session. I have no gifts or stock, or I'm not receiving any large sums of money to promote somebody's product during this. Someday it's my goal to have a conflict of interest statement that said, yeah, these guys are paying me a bazillion dollars. Sadly, not today. So I have no conflict of interest. Our objectives today are going to be at the conclusion, hopefully the pharmacists are going to be able to explain the impact our pharmacy teams have made on gap closures through vaccination services, identify vaccine hesitancy, social determinants of health, and disparities in health equity within the populations we serve, describe methods for addressing vaccine hesitancy, social determinants of health, and disparities in health equity, and identify what contributes to vaccine hesitancy, SDOH, and disparities in health equity. That's a bit of a mouthful. I think we can get through it. After we put these together, we also had to develop technician objectives, and being that I am absolutely too lazy to go through that twice, our technician objectives are the same as our pharmacist objectives, but I will give you the caution that a lot of this CE program has to do with utilizing technicians to their full potential in order to close some of these vaccination and healthcare gaps. So technicians, pay particular attention to this. A lot of this has to do with you and the future of our pharmacy practice. I'm going to run through a few pre-test questions. We put 4 of them together, the first of which is vaccine hesitancy can in part be attributed to low vaccine confidence, misconceptions regarding vaccines, issues of social determinants of health, or all of the above. Our question number 2 is community health workers, CHWs, working within a quality med-sync program can positively affect vaccination rates and close gaps in care? True or false? Our third question is, what can pharmacy technicians, cross-trained as community health workers, utilize to identify vaccine hesitancy, social determinants of health, and health equity disparities? SDOH screenings, community diagnosis review, motivational interviewing, or all of the above? Our fourth and final pretest question is, through the HRSA program in southeastern Missouri, how many vaccine gaps were accomplished by pharmacies for the COVID vaccine? 46,000, 15,000, 75,000, or 325? Now, as we go through the presentation, all of these questions will be answered within the confines of that presentation. So if you just listen with one ear, maybe not both, I think you'll come up with all of the answers to these, and we'll talk about them again towards the end of the session. Welcome to my glamour shot. As an introduction, and just so you understand that I didn't just fall off a bar stool and stumble in front of this microphone to present this CE session, I'm Richard Logan. I'm a community pharmacist from Charleston, Missouri, in the far southeastern part of the state. And I am a dinosaur. I've been doing this a long time. As a matter of fact, I have been on the same street in Charleston, Main Street, since 1976. In 2002, my son Trip Logan, PharmD, joined me in practice, and from that point, we developed a mission statement. And our mission statement, you can read it here: to optimize medication use, evolve healthcare, and implement the overall well-being of members in our community. We actually take this pretty seriously. We want to evolve healthcare, and I think during the presentation you'll see where that has been done. When I started in practice, I received a call from a local physician who was, in 1976, had been in Charleston a long, long time. And he said, I have this prescription here that you filled, and on the bottom of the label it says Benadryl. Did you type in Benadryl on this label? And I said very proudly, why, yes, I did. That was my first chewing by a physician. He told me at the time, if I want my patients to know what they're taking, I will tell them, you are not to label any of my prescriptions for my patients, nor are you to talk to them about said medication. Well, I went ahead labeling all of his prescriptions and talking to his patients about their medication. But this is the evolution of healthcare in our area that we've been trying to facilitate for pushing 50 years now, in order to improve the overall well-being of members of our community. Now, understand, these are all community efforts. I really can't affect the health care of people I don't serve, and I serve members of our community. Just to give you a bit of an idea of what this community is like, I've mentioned far southeastern Missouri. What you see here is a picture of I-55 southbound at the 82-mile marker. Now, if you're unfamiliar with I-55, it basically runs from Chicago to New Orleans, through the eastern part of Missouri, St. Louis, Cape Girardeau, and south towards Memphis. At mile marker 82, south of Cape Girardeau, you'll see coming down this hill that the earth flattens out. The hills are left behind, and you're left with flat driving as far as the eye could see. Mile marker 82 on I-55 southbound is where the world changes. You leave the hills behind and you enter what is known as the Mississippi Delta region of the country. Now, the Mississippi Delta region is well known for significant challenges related to poverty, social determinants of health, inadequate housing, food insecurities, insufficient access to education and health care are rampant in this area. Racial disparities, food deserts, poor access to transportation are things that we see throughout this region. And in the little blue box in the northern part of the Mississippi Delta region is where you'll find me in Mississippi County, Missouri. We refer to this as the land of sweet tea, fried catfish, hush puppies, and fried chicken, or as I refer to it as Tuesday lunch. Of the 115 counties in Missouri, Mississippi County, Missouri is rated 112th out of 115 for poor health outcomes. And this rating is basically how healthy a county is right now in terms not only of length of life, but of quality of life. And that sounds really, really bad until you go one county south of us, and it's the 113th worst health outcomes county in Missouri, which sounds even worse, except if you go one county south of there, just following the Mississippi River, you find the 115th worst rated county in Missouri for health outcomes. These are the people we serve. This is the area we serve. These are our patients. The Missouri DHSS performs county surveys. And in our county, in Mississippi County, where I'm sitting right now, they found that 60% of the folks received no flu vaccine. 60% in my county. That's staggering to me because we offer flu shots. Our health department, public health, offers flu shots. But 60% reported no flu vaccine in the last year. Not only that, CDC reports statewide that nearly 30% of Missourians over the age of 65 have no pneumonia vaccination. And yes, I did select the little figure at the bottom of it because of his resemblance to me, although I have to admit I do prefer red suspenders to brown suspenders. If you think about no pneumonia vaccination in 30% of the people over the age of 65 in Missouri, pneumonia used to be called the old person's friend, because if you got sick and went to the hospital, you could come out an invalid, but if you were lucky, you would get pneumonia and just die. This is the history of pneumonia in this country. And yet 30% of the people my age, over 65, don't have a pneumonia shot. These are what we call gaps in care, especially vaccine gaps in care. And what we are concerned with, and especially learning about in this presentation, are how do we close those gaps in care? So I guess the first thing we have to do is talk about, why is this important, and what can I do about it? If you look at the graphic on the right, this is pre-COVID, and you can imagine how exponentially more costly post-COVID this is. But pre-COVID, we spent almost $6 billion just on flu in this country. Now, this is a vaccine preventable disease. Pneumonia, we spent nearly $2 billion on pneumonia in this country. Once again, a vaccine preventable disease. Compare the cost of a vaccination to the cost of treatment, and just see why this is important. To give you a couple of quotes, vaccines are one of the safest and most cost-effective health interventions with numerous social and economic benefits. Two key words here: safest, cost-effective. Safest, cost-effective. These are things we as pharmacists can provide for our patients that are not only safe, but they're cost-effective. And if you go to the second quote, vaccines that save thousands of lives in the United States every year, but many adults remain unvaccinated. So as we think about closing vaccination gaps, as pharmacists and technicians, we have vaccines that are safe, cost-effective, and save lives. Safe, cost-effective, and save lives. That's something that we can give to our patients through our clinical services that pay benefits and dividends to those patients. So let's think about it. If we have this service we can offer, why do patients not get it? Why do 60% of people in my county not have a flu vaccine? Why do 30% of people over 65 in Missouri not receive pneumonia vaccine? And what can we do to affect that? Let's begin by addressing vaccine hesitancy and access. We're going to talk a little bit about that in just a minute. We're going to do it so that we can improve vaccination rates. But in order to do it, we're going to have to do this within your workflow. It has to be able to be performed in the pharmacy. And doing that, we're going to talk a little bit about how we can address multiple patient comorbidities along with vaccination rates and really affect our patients' overall health care in a positive way. Let's talk about vaccine hesitancy and begin in the era of COVID. Some studies have found that COVID, people were refusing the vaccine because they had no confidence in the vaccine. Um, it I heard comments as we were doing outreach clinics. Uh, well, it's a new vaccine. I don't know what's in it. It's not been tested. And then there were misconceptions about it. Um, oh, Lord, were there misconceptions about it. Uh, they're implanting, they being the health authorities, were implanting chips in us. I actually had a 30-minute conversation trying to convince a woman, no, with the COVID vaccine, you will not become magnetic. And just because you saw it on Facebook doesn't mean it's true. There were all sorts of misconceptions about it. And the politics of COVID, uh, whether it was red or blue conversations, everyone seemed to be putting COVID, making it a political football instead of focusing on quality patient care. Um, Everyone seemed to be focused on political sound bites and not really keeping people out of the hospital. Um, and folks in my area just really don't trust health authorities. Um, I I would imagine that it's quite the same in your area. We had federal efforts where Army trucks pulled up and people in uh, uniform came out to give shots. It was set up like a military exercise, which was marvelous for those who trust health authorities and trust the healthcare system. In my area, we saw a lot of those things, that type of vaccination outreach being used by people who were not residents of our area. Um, it just did not speak to them on a level that they would have confidence in becoming vaccinated. And to all that, not only low vaccine confidence, the misconception, the politics, and the mistrust of that were keeping people from getting vaccinated. I would add there were also social determinants of health factors like food transportation, food insecurity, low health literacy, housing. If you don't know where your next meal is coming from, uh, the thought of getting a vaccination is probably not real high on your list of priorities. Um, Anything, especially in poor areas and underserved areas, that keeps a person from care can lend to vaccine hesitancy, along with the other things listed here. But what we found during our vaccination outreach programs is there's a secret weapon that became utilized during COVID, and that was the pharmacist. The trust that people have in us, the ability to communicate, the patient access we have, all helped with uh, increasing vaccination rates in our area. And we're going to talk a bit more about that in just a minute. But what we found as pharmacists is we can't do it alone. We have to have help. This is a large undertaking we're talking about. Enter the community health worker, and more specifically, the community health worker in pharmacy practice. If you're not familiar with community health workers, a community health worker is a frontline public health worker who is a trusted member and has an unusually close understanding of the community served. This trusting relationship enables the CHW to serve as a liaison between health and social services and the community. And a community health worker has the capability to build individual and community capacity by increasing health knowledge and self-sufficiency. Now, this is a classic definition of a community health worker, not necessarily a pharmacy community health worker. I think what you'll find if we dissect this just a bit is that a community health worker is a frontline public health worker who is a trusted member of a community and has an unusually close understanding of the community served. Think about that for a minute, and then think about that in relationship to your pharmacy technicians. Further, this trusting relationship enables the community health worker to serve as a liaison between health and social services. I don't know about your pharmacy technicians, but that sounds like a lot of what my pharmacy techs do on a daily basis. So we have incorporated community health workers cross-trained in our practice. We're going to talk a bit more about that. If you have a community health worker and task them with addressing health inequities and help close gaps in healthcare, what we find is they can help us bring health equity to individuals locally and close gaps in care. Now, we need to talk a little bit about health equality and health equity because there's a difference. The differentiation may be subtle, but it is there. If you look at the graphic, health equality in this particular situation would be everybody gets a bicycle. Now, if you're in a wheelchair, a bicycle does you no good. Just as if you may have access or there may be quality health care in your area, but if you can't get to it, then that is a health care inequity. You may be able to have equal care, but you can't access that care because of health equity. Now, health equity on the bottom part of the graphic is if each individual, and now this is individual care, if each individual has access to care appropriate to them. Do you have transportation to health care? Can you focus on your health care if what you're really worried about is where your next meal is coming from? And once we satisfy where your next meal is coming from, can we begin to close gaps in your health care? In closing these gaps, community health workers, and specifically community health workers cross-trained as pharmacy technicians, bring a lot to the table. In their bag of ammunition, they bring motivational interviewing, screenings for social determinants of health issue, community needs assessments, which are also called community diagnosis review. These are tools in the community health workers' bag of tricks that they can bring to a patient to help them access care, close not only vaccine gaps, but other issues too. Motivational interviewing can bring, if it's done on a patient-to-patient basis with someone with whom they're familiar, you can start on one subject and you can bring out a patient's needs through motivational interviewing so that you can begin to address their social determinants of health issues. You can bring formal screenings for SDOH issues. Through the community needs, community diagnosis review, CHWs cross-trained as pharmacy technicians have a reference list of services that can be recommended to a patient for referral. And this can not only be done with vaccine hesitancy, but it can be done with social determinants of health issues to address health disparities. If a patient needs an appointment with a physician, perhaps they don't have transportation once that appointment's made, CHWs can help address this in your patient population. We discovered this with a HRSA grant during COVID. During the initial COVID vaccination rush, we had three groups of people. One group, the first group, was all about the vaccine. We want it now. As soon as you get it, I'm in line for it. We addressed those people with mass vaccination clinics locally. And we ran through that population in the first couple of months of vaccine availability. The second group was I'm not so sure about this. I'm going to wait and make sure the first group doesn't grow tails or they don't all become magnets and stick to their refrigerators. And the third group was, no, not me. I'm not going to be vaccinated. I don't like needles. I don't like vaccines. It's just not going to happen. After the mass vaccination clinics, we began to address groups 2 and 3, the vaccine hesitant and the vaccine deniers. I will not have a vaccine. And among this group was a lot of people affected by social determinants of health issues. The grant itself was about a 6-month grant, covered 16 counties in southeast Missouri. The pharmacists in this developed a cold chain of distribution so we could distribute Pfizer vaccine across these 16 counties. We had our pharmacy community health workers work to support our clinical outreach efforts. There were over 50 other community health outreach workers that were engaged throughout the 16 county area to work in conjunction with our pharmacists, our pharmacy CHWs, to provide over 325 community clinic events. Our pharmacists did over 46,000 screenings of high-risk patients. And our pharmacists and community health workers provided over 75,000 individual education touches to patients. We talked to individuals over 75,000 times, and our pharmacists provided about 15,000 COVID vaccinations. You might have seen these numbers before. I think in this area that 15,000 COVID vaccinations is in 6 months quite a feat when we were using our CHWs to address vaccine hesitant people, providing education and SDOH services to bring them to our 325 clinics. The gist of all that is pharmacies gave a bunch of COVID shots. We stepped out from behind the counter during COVID. We changed the perception of pharmacy. And if you'll look at this, I find this graphic from IQVIA extremely interesting. The area of green at the top of those blue bars is non-pharmacy medical claims for COVID vaccination. The blue claims, the blue areas, those are pharmacy claims. Look at the percent of COVID vaccination done by pharmacists as compared to non-pharmacy medical settings. Folks, we knocked this one out of the park. During COVID, we were Babe Ruth pointing to left field and then stepping up to the plate and hitting the ball out of left field. We told people we could do it, and we did it. As a result, we developed a lot of street cred. This was an evolutionary change, or maybe a revolutionary change in the public perception of vaccinations. People now viewed pharmacies as not only a place to go and receive a prescription, but as a healthcare center to find out about vaccinations, vaccine-related information, and other more complex healthcare issues. How do we know that it was an evolutionary change? Well, because it's not just COVID. These numbers are from an IQVIA report in January of 2023 covering COVID, flu, HPV, pneumonia, shingles, and Tdap. And if you look at the graphic, there are a lot of vaccinations done in pharmacies. Among these, much more so than in non-pharmacy medical settings. And if you'll look at the inflection point in Q3 of 2020, coincidentally COVID vaccine era, that's where the blue line of pharmacy trending vaccine administration really begins to rise. That tells us how important our participation and our being community pharmacies' participation in vaccination efforts is. It's important that we offer these services, as we saw on an earlier slide, to not only develop a stream of revenue for the pharmacy, but to provide these clinical services that foster better patient outcomes and better health care for our patients. Well, what about me? What about my practice? That's always a question we get when making these presentations. If your practice is anything like my practice, we have a set of patients, some of which don't need high touch pharmacy care. Basically, all they need is a prescription filled at the pharmacy. But about half of our patients are chronically ill. Um, they're the ones that we see more often. They're the ones that need more care. And about 10% of that 49% are our high risk, chronically ill patients who are the most in need, usually the most needy, and the least well equipped to access care in any convenient fashion. This is the patient we begin to focus on, our 10% chronically ill patient. If you focus on the patients in need, and here again, sometimes that need is a desperate need, you can make a sizable impact in the quality of their lives, help close gaps in care. You can increase vaccination rates, and you can lower the chance of poor outcomes. The person you see on this slide is my longtime pharmacy technician / community health worker, Bonnie. This is the area in which these people can shine, taking care of our sickest of the sick and neediest of the needy. Just to relate a short story, Bonnie was doing outreach calls and couldn't reach one of our patients. And we knew that this was an issue because the patient had a long history of mental illness and was in need of some fairly high touch care. When we couldn't get hold of him, Bonnie, who is from our community health worker, called one of his family members, his cousin, in fact, and said, I can't get hold of this patient and we think we need to, and found current contact information, got hold of the patient, tried to carry on a conversation with this patient, and the patient was all over the board, unable to carry on a coherent conversation, enough that it alarmed Bonnie. So Bonnie reached out to the pharmacist, the clinician that was next to Bonnie, and said, this is what's going on here. So the pharmacist looks, and lo and behold, this patient hasn't had their injectable antipsychotic in months and months and months. Had missed appointments at the physician, at the mental health provider. And Bonnie set about making all of these appointments for this patient. And within 6 hours, Bonnie had the patient contacted, the family contacted, appointments made, and the patient set up to see their mental health care provider. And in order to avert a situation that wasn't going to get anything but worse over the next days and weeks. I saw this patient just bare weeks later at one of our vaccine outreach clinics and gave him a COVID vaccination. Now, had Bonnie not been able to do everything that a pharmacy technician / community health worker could do, this person would have had that they wouldn't have been at that vaccination outreach, able to carry on a coherent conversation with me. They would still be in the throes of a mental health crisis or suffering the effects of a mental health crisis. Um, this is how you improve gaps in care. This is how you help your patients. But it will not work unless it works in your business model. Now, you tell me what your business model is. I'm a community pharmacy owner. I lose enough money on prescriptions these days that if my business model is to fill more prescriptions faster, then I'm going to lose money. I have yet to find a way to lose money fast enough to make money. What we're focusing on is an evolutionary expansion of our service offerings to source new revenues and enter the value-based payment model. And we're doing this with help of our community health workers. These are 6 of my 11 community health workers that I have on staff. Our cross-trained community health workers have a deep understanding of pharmacy procedures, a deep connection to our patients, and they're empathetic and able to assist those patients. What we do is we assign community health workers a cadre of patients. We incorporate our community health workers into our monthly MedSync calls. And I will tell you that if you're considering this for your pharmacy practice, it cannot be done without a robust MedSync program. This is not a once a month you call Mrs. Smith and say, we have your prescriptions ready, come pick it up. This is a community health worker outreach call to a patient about their medication, about how you need to focus on your health care. And in this call, we're focusing on whether it's flu shots or shingles vaccine or pneumonia shots. This is a robust MedSync outreach program that the pharmacy utilizes to provide better patient care to patients, open up new lines of revenue, and provide closure of gaps in care that patients need. It's all done with a fairly directed script. You give your community health workers something to talk about, whatever the focus is. If you're promoting flu shots, make sure your community health worker has done their homework. Well, Mrs. Smith, you need your flu shot. No, I've already had it. If you're doing that, you've wasted a call. You've wasted the time of your community health worker. You do your homework and you offer services that patients need that close gaps in care. And you do it on the back of a robust MedSync program that's dedicated to improving patient care. And it's all done within steps of a clinician. So as we think about community health workers doing MedSync calls, The keys here are focus on high-risk patients in the beginning, expand after that. The patient develops a rapport with his community health worker and becomes comfortable with these conversations. When that happens, the patient is much more likely to open up about other issues and is very likely to accept recommendations from this friendly community health worker that they know calls them once a month to talk about their health. They're much more likely to accept recommendations for vaccinations or other services. This is a very sustainable practice model. You can use it to increase revenue. It provides healthcare services to patients who need it most, closes vaccination and other gaps in care, and opens many other opportunities for your pharmacy practice, whether it's participation in other grants that are going on, or collaboration with local health departments. A lot of opportunities open up when you use community health workers, improve gaps in care, and do community type outreach. There are a lot of opportunities there that can be taken advantage of. Take-home points. Vaccination services not only close gaps in care, but they improve patient lives. A vaccination service needs to be coupled and must be coupled with a robust MedSync program. And there are many business models out here that support having pharmacy technicians / CHWs on staff to help address not only social determinants of care issues, but close vaccination gaps and other health gaps. So in conclusion, let's run by the post-test questions and see if they make more sense now than they did in the beginning of this presentation. Vaccine hesitancy can in part be attributed to, is it low vaccine confidence, misconceptions regarding vaccines, issues of social determinants of health, or is it all of the above? I think by now we can safely say that all of these things can contribute to vaccine hesitancy, whether it's I can't get there, which is an SDOH, transportation issue, misconception regarding vaccines, no, you really don't become magnetized, or low vaccine confidence. Well, I hear that if you take a flu shot, it'll give you the flu, and I'm not willing to do that. All of these things contribute to vaccine hesitancy, and all of these things can be addressed by CHWs and pharmacists in communication with patients. Our second post-test question: community health workers working within a quality MedSync program can positively affect vaccination rates and close gaps in care. I think we can absolutely conclude that that's true. We talked at length about the need for a quality MedSync program. It's the communicational foundation of everything that we do in our practice and what we've seen in other practices. It's the base from which everything else is built upon. What can pharmacy technicians cross-trained as community health workers utilize to identify vaccine hesitancy and health equity disparities? What do they have in their toolkit? SDOH screenings, community diagnoses review, and motivational interviewing. Yes, these are all tools that the community health worker brings to the table. And our last post-test question, the one that we had to have one with numbers in it, so this is our one with numbers in it. Through the HRSA program in southeastern Missouri, how many vaccine gaps, vaccinations, were accomplished by pharmacies for the COVID vaccine? Was it 46,000, 15,000, 75,000, or 325? And the answer is 15,000 vaccinations were given. And this number always amazes me because it was done in 6 months across some of these counties that barely have 10,000 people in them, period. Now, the 75,000 you see here is patient education contacts. We may have talked to some of those people 7 times before we got them vaccinated. But that's an effort well worth having in a conversation that needs to be done as many times as necessary to get folks vaccinated and help protect their lives. In conclusion, these are some resources that contributed to this presentation. I think this first one, the one that says www.countyhealthrankings.org, might be the most interesting to you. If you go in and click on your county, you can see how your county ranks in the state. It's quite telling and can help you mold what your practice, mold the direction in which your practice needs to go to address health disparities in your area. I would suggest going to that link and taking a look at the information there. I found it very valuable. In conclusion, this is my contact information. Richard Logan. My email is rlogan@semorx.com. Remember, we talked a lot about Southeast Missouri or SEMO. rlogan@semorx.com. I answer my emails. If you have questions, please feel free to forward them to me, and I will answer them as they come in. That brings us to the conclusion of this presentation. I thank you for your kind attention and hope we overcame the cheesy cartoon at the beginning. But if you'll remember, if the little man in the little booth at the beginning had been vaccinated, he would have still been there to give them excuses not to be vaccinated. So thanks again for your attendance, and contact me if you need further information.